Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Hi, everyone, and welcome back to the Skin Sync podcast. This is Buchi, Neita, and I'm back again with Lisa Weiss, and we're here to talk about non-scarring alopecia. So, Lisa, let's kind of start with something that I know it's really relevant to you, that really kind of speaks to your heart, to your experience, androgenetic alopecia. So, tell me about your personal journey with that. I know you mentioned that it was a diagnosis you've had since a very young age, and what it means to you when you're actually treating your AGA patients.
Yeah, so AGA is very near and dear to my heart. I am an early 40s woman and I'm a Caucasian female in my early 40s. And I was diagnosed with androgenetic alopecia at age 24. And I did notice over time and while I was in college that my hair had gotten a little bit thinner, but everybody talks about how your hair changes texture over time. But my mom even noticed that my hair and my ponytail was getting smaller and that my hair was getting thinner. And it's never a problem that she had dealt with. So she mentioned it to me and she was like, I think your hair is getting thinner. Maybe you're like hot ironing it too much or drying your hair too frequently, but your hair just looks like it might be getting thinner. And at the time I was working as a medical assistant to get my hours for PA school. And I brought it up with one of the physicians that I was working with. And she said, you're on the young end of the spectrum, but there are women that get diagnosed with androgenetic alopecia in their young 20s. Like, let's do a biopsy and check and see what it is. And lo and behold, I had androgenetic alopecia that was diagnosed in my early 20s. And I did exactly what I was told not to do. And I went home and Googled what androgenetic alopecia would look like.
Of course you did. Why wouldn't you?
Of course. And, you see these bald women that have just like very little hair on the top of their head. And I was engaged and getting married. And I was like, great, I'm going to be a bald bride. And I was, so, I mean, it's funny to laugh about now because I have a full head of hair.
Right.
And
But how distressing for you back then? I mean, I can't fathom the idea of being that young and getting this long-term chronic diagnosis that has no cure for it. And that has to be pretty emotionally distressing for you.
It's incredibly emotionally distressing, but I will tell you, having that diagnosis at a young age has really empowered me to, I think, be a better provider and a better caretaker for my hair loss patients and hair loss of all types. When I walk in the room with a patient who's stressing over hair loss, whether it's telogen effluvium, androgenetic alopecia, CCCA, whatever the diagnosis is, when I look at the patient and I say, I understand you, I'm a hair loss patient myself, it brings the whole room energy as we are working as a team. And I understand what you're going through and I understand the tears. And I even say to them, I'm going to tell you right now to not go home and Google what the diagnosis is that I gave you, but I know full well that you're going to go home and Google what the diagnosis is, but that what you're going to see online is the worst case scenario of the diagnosis, not what I'm going to do for you. And I think that being a hair loss patient and going through the journey and having hair and knowing great ways to manage it and knowing that it can be stressful at times has made me a better provider and has made me more relatable to my hair loss patients.
I think as you say that, actually, it makes perfect sense because I've never really thought about it that way. But as I sit here and think about my patient encounters, I've had 3 different forms of hair loss over the years. And, because on this podcast, we share all of our mental health and medical history. I've actually had issues with traction alopecia, still battle with that. At one point did have a patch of alopecia areata years ago in college. And then, of course, postpartum telogen effluvium. And when I mention this to patients, whether, whatever diagnosis we're talking about, I think there's that automatic connection where they're like, okay, well, you get it. You understand, like you understand the struggle that they're going through. And it really does a lot. So for those that are comfortable, obviously, you're welcome to share your journey, your battles, your difficulty with hair. And I think patients really do find that kind of comforting to know that you've been through it too.
And to know that I have hair on the top of my head. Like,
right.
I'm not
There's
a bald.
Yeah, there's hope. We're not a bald bride. There's hope. Yes.
And yeah, exactly. I'm not a bald bride. I have hair on the top of my head. And I tell them, I got to that point that when I was drying my hair, I could see my scalp in the center, and I don't have that anymore. And the same treatments that I used, if it's an AGA patient, I can give to you, and there are other things I can give to you, and we can work on this together. So I think it makes it very comforting. I've also been a telogen effluvium patient, and with so much of that in the GLP-1 space right now, talking to about postpartum or GLP-1 or stress or that period in COVID when we had so much telogen effluvium, being able to talk about, like, you know what it's like to have telogen effluvium, you know what it's like to have AGA, you know what it's like to have traction alopecia. It's that relationship that you can build with the patient.
Absolutely. So let's kind of talk about AGA in more detail. We know it's the most common cause of hair loss, right? And now, is this typically amongst the entire population, both men and women, or is it specific to one population as far as the commonality of it?
I believe it's both men and women, and the
Okay.
commonality is there.
Okay.
I see a ton of androgenetic alopecia in both men and women. I think we're very accustomed to know what the pattern looks like in men, and we're very accustomed to know that as providers, that with females you do see that widened part. But sometimes if females have a lot of hair on their head, you might not notice the widened part quite as much. And you might not notice that they do have that same bitemporal recession that you see in men, because with long hair, sometimes it's easy to cover up, or with a big swoop bang, you can cover up that bitemporal recession that you see.
Absolutely. And I think this is where it's really important, just like we mentioned in the previous podcast, to get those tools out, get that dermatoscope out. You really can't do a proper hair assessment without it. And look for the miniaturization of those hair follicles. And that's pretty much AGA, unless otherwise specified. But I think it's really, really important to do that proper exam because, again, it may not always be the typical pattern. And especially for women that have textured hair, again, sometimes it's a bit more subtle. It's harder to see. So get your dermatoscope out and get in there and do a proper exam.
I think the dermatoscope is so important when you're dealing with a hair loss patient. It can give you such good clues as to what you're actually dealing with. And it can also show if there's overlap of different types of hair loss. So sometimes you are seeing that variation in the hair shaft diameter, but sometimes you're also seeing some empty hair follicles, and you realize that there is that overlapping telogen effluvium and androgenetic alopecia patterns that are overlapping on themselves. So
Absolutely.
as an androgenetic alopecia patient who's had two babies and had terrible telogen effluvium after both of my pregnancies, I'm sure that my scalp dermoscopy is something that could be in textbooks.
Definitely. And I think one thing that I didn't know much about, and I think that we're hearing more about now, is the hormonal component with this too, specifically when it comes to insulin resistance and just kind of androgen excess when it comes to women, right? There was a report that showed, I don't know which GLP it was, if it was tirzepatide or semaglutide, but a male patient who was on no other therapies for his AGA had significant regrowth after being on a GLP for several months. So again, there's something to be said about that insulin resistance and kind of hormonal disturbances or metabolic syndrome with AGA. And with women too, we know that obviously with PCOS patients, we see a lot more AGA or even sometimes just kind of that male pattern hair loss. So it's important to be on the lookout for some of these disorders as well.
Right. But we can't forget about that telogen effluvium that happens when they do have that rapid weight loss from the
Yes,
GLP-1s.
yes, yes, absolutely.
Because they may get good hair growth over time, but we definitely are seeing significant amounts of that telogen effluvium that happens from the rapid weight loss as well.
Absolutely. So, what are some of your kind of go to treatments when it comes to AGA? Do you base it on the patient's age, their gender, where they are in their reproductive life? Are you looking at, their compliance rates? What are you using to treat this condition?
I always talk about all of the treatment options that are on the market. I think it's really important. And I do this with almost every diagnosis. We're so lucky in today's world with almost every diagnosis in dermatology, with a few being exceptions to this rule, that our toolbox is full of things that we can use to treat. So I always start as simple as topical minoxidil is a great option to use and treat. I will tell you personally, and I think that as a hair loss patient myself, I understand this. Topical minoxidil is greasy. And I think it's very easy to recommend it to patients and be like, you don't need to use orals, you can use topicals. But until you have put topical minoxidil in your scalp, and especially if you are a hair loss patient and you are worried about the amount of hair that you have on the top of your head, when you put topical minoxidil in thin strands of hair and you are a white female who already has oily hair, you feel like you have a grease trap on the top of
Right.
your
It's
head.
not a
So
good look.
I'm not a huge proponent of using topical minoxidil in women. I always, and men, I offer it every single time and I tell them it's a safe, easy, affordable, over the counter option for them. But I do stress that it's greasy. So if you're worried about your hair being greasy, this probably isn't a great treatment option for you. And it only works if you use it all the time.
Yeah.
So I really stress that. Go
So
ahead.
another thing that I keep in mind when it comes to topical minoxidil is for those that have maybe textured hair who don't mind a little bit of the greasiness, it's the compliance piece, right? It's really
Absolutely.
hard to try to use this product every single day, especially those that aren't washing their hair every day, who aren't really doing a lot of hair care routinely. And so I think it's important to keep in mind that it's not always realistic for patients to use this topical routinely. And also, it can be irritating. There's propylene glycol in the over the counter topical minoxidil. So sometimes those other components can be really irritating to the scalp. I do sometimes offer compounded versions, maybe in a cream formulation or an oil formulation that can be really helpful. You can increase the potency of these topical compounded formulations to maybe a 7 or 8% minoxidil. You can even add tretinoin to it, which has been shown to make it more efficacious. So there's little tricks that you can do to try to increase the compliance and tolerability, but it's still hard for a lot of patients.
It's definitely a hard ask. I'm a big proponent of using oral minoxidil. Oral minoxidil and I use this analogy a lot for those of you that are old enough to understand it, is my Windex in dermatology. I just love oral minoxidil for hair loss. I think it works incredibly well. I think it's really affordable. I think we're using a really low dose that has a really clean safety profile, and it works, and it works well. And I think it comforts my patients to tell them, I take oral minoxidil every single day. It's something that has changed my hair growth and has no side effects for me, and it works incredibly well. So that brings comfort to my patients when I talk about this is something that I take every day. And these are the side effects that I do see. I stress to women, you're going to get more of that peach fuzz, like vellus hair on your face if you're taking oral minoxidil. You're going to notice a little bit of hair loss when you first start taking it. You're going to get a little bit of that shedding, and it's just kicking out the hairs that were going to come out anyway. So I stress, like if you see leg swelling, this might not be the drug for you, but don't worry, I have other things that we can use. So I love oral minoxidil. I take it myself. I have every member of my family on oral minoxidil if they have any sort of hair loss problem. And I use it in clinic on a regular basis. I feel very comfortable with it. In fact, I just taught a lot of the APPs at my office about how I use oral minoxidil and why I feel comfortable using it, because I do have such great success with it. It works incredibly well, in my opinion, with a very, very clean safety profile.
I agree completely. It's my favorite thing to prescribe at this point for not just AGA, but for most forms of hair loss, to be quite honest. I
Agreed.
will say from personal experience, if you are naturally prone to male pattern hair growth on your face or elsewhere, you will see more of that. So it's not always just that peach fuzz. Sometimes it's the thick, dark, coarse hairs that are just icky, and you might want to go get that lasered. So something to keep in mind along with body hair as well. But I think it's an incredible medication. It does require the consistency. Patients do sometimes want to skip days or take it every other day. It has a relatively short half life. You do need to take it pretty consistently, but it's my favorite thing to write because it works. We have so few things that work so well that why not oral minoxidil, especially seeing how safe it is.
Right.
Any other therapies that you're prescribing for patients with AGA?
Yeah, I mean, like I said, I recommend everything. Oral minoxidil is definitely my favorite, but I do use finasteride. I do use dutasteride. If I'm using either of those in women, they are postmenopausal women. I don't use those in women of childbearing potential. I still use a lot of spironolactone, and I use spironolactone in combination with oral minoxidil. I make sure that if I'm using spironolactone, that I counsel about, different things that you can see with spironolactone. I'm a terrible water drinker, so spironolactone's not a great drug for me personally, but that's a me problem. And I always stress to people, if you're good at drinking water, spironolactone's a great add-on to oral minoxidil for AGA for your women. I do think it really, really helps with that hormonal component of hair loss. And then I always talk about hair transplantation and I talk about using PRP in combination. I think those procedures do really benefit patients and can be used in combination. But I agree with you, stressing the importance of taking these medications on a daily basis is a big part of this. And that just like they have to take their blood pressure medication every day and for the long term, your hair is the same. And these medications are with you for the long run unless we find out that there's something that you can use for shorter periods of time.
Yeah, I feel like when I get any kind of reluctance for patients to be on oral minoxidil, it's usually that they don't want to be on a medication forever. I'm like, well, you want to keep your hair? So I just sometimes have to be really upfront with them and just let them know that you don't have a lot of options. And no matter what you do, whether it's topicals or over the counter supplements, if you have improvement, this is something you are on indefinitely. So be prepared for that. And some patients will choose not to, for that reason. Couple other things I'll mention. If you are prescribing oral finasteride for patients or even topical, you might want to be cautious because there is this website. It's the post-finasteride syndrome where there's patients out there who felt like they had serious side effects from the medication, particularly erectile dysfunction, decreased libido, some who felt that their symptoms did not reverse after stopping the medication. And there's a big campaign out there to get people to stop taking finasteride. I don't think it's working. It's still widely popular, and prescribed. But I warn every single patient, male or female, about this potential side effect. And I just want to CYA, right? Just be cautious and
I
make
do
sure that you're advising them.
I do the exact same thing. And I think patients sometimes Google what are good treatment options and they see finasteride and they've heard from other people that they've been taking it, people who have had hair loss for a long time. That really was the mainstay. And I do think for those of us who treat hair loss on a fairly regular basis, a lot of us have made that switch to using more oral minoxidil than we are finasteride and dutasteride. And I always stress to patients, these are real risk factors that come along with using these drugs. And as long as you're fully aware that these are potential risk factors, I'm fine using these drugs for you, but you do need to know that this is a potential side effect.
Exactly. And then one more thing I'll mention as far as the treatment goes is the low level light therapy. So red light is all the rage right now when it comes to skincare and anti-aging. But these devices have been around for a long time when it comes to the scalp. And there's so many of them, it's hard to really decide what's a good quality device. I think it's important to tell patients if you're choosing to invest in one, because it is an investment, they are all very expensive, that you do want to get one that's FDA cleared. I usually give a few recommendations to my patients directly and also remind them that, again, this, along with every other treatment, requires consistency. And so if you're not being consistent, you are not going to get the results with this device. So it's not worth your $1,500 investment if you're not really going to be using it consistently. Do you recommend those light therapies at all?
I do. I like the light therapies, but I tend to tell them I really can get you great hair growth with an inexpensive oral medication.
Exactly.
So if you're willing to try an oral medication first, and I really do get good growth with the oral medications, that
Yes.
when I stress that to patients, I'm like, before you invest a lot of money, we can try something less expensive. If you want to use the topical red light therapies as an add-on or as an adjunctive therapy, I'm happy to have you use them. But I do always stress to them that I know these tried and true medications work incredibly well, and they're going to be a lot easier on your pocket.
I agree 100%. So, moving on from AGA, let's talk about alopecia areata, a condition that we are seeing or hearing a lot more about now because we've got 3 FDA approved treatments for it, which I've definitely utilized in clinic and been really impressed with some of these results. But with alopecia areata, obviously we know that we get the patchy distribution in most cases, typically non-scarring, but we do have patients that have the more severe eruption. You mentioned ophiasis pattern in the past. We've got alopecia totalis, where they've lost the entire hair on their scalp, and then universalis, where they've lost essentially everything on their body. But what are some of the diagnostic clues when you're looking at maybe a patch of questionable alopecia areata? What are some of the things that are going to clue you into that diagnosis?
Using your dermatoscope, I think, is really important when you're looking at an alopecia areata patient. I looking for exclamation point hairs, I think, is really important when you're looking at alopecia areata. And also asking about potential other autoimmune diseases, I think, is an important part of diagnosing alopecia areata. And I always look at their nails. It's one of my big clinical clues and sometimes can be incredibly helpful when you're diagnosing alopecia areata to look and see if there's nail pitting. So I use that on a regular basis. And then also just to make sure that I have the correct diagnosis, I check for lymph nodes when I'm looking at alopecia areata just to make sure that maybe it's tinea and I'm giving them the diagnosis of alopecia areata, but a quick check of those lymph nodes, and sometimes you can very easily differentiate the two if they're lymph node positive.
A
So just
hundred
a little
percent.
trick that I do.
That's
Takes
a
two
great trick.
seconds and you know.
Very,
So
really good trick, especially in pediatric patients who we know also get alopecia areata, but are also at higher risk for tinea capitis as well. So really, really great trick. So when it comes to managing alopecia areata, we know that we've got lots of options depending on the severity of it. Typically, my go-to is always going to be intralesional steroid injections, particularly triamcinolone. I know topicals can be helpful to an extent, but my understanding is that that inflammation is going deep into that hair bulb, and oftentimes topicals really aren't going to be that effective. So intralesional steroids, if patients can tolerate it, are really going to be my go-to. One thing you can do if you know it's going to be an ongoing thing is prescribe a topical numbing agent like a BLT ointment prior to their appointment, and it does take the edge off of that injection. But what else are you doing for your AGA? Or sorry, your alopecia areata?
I do the same thing. I always recommend injections. A lot of times the patients want things in between treatments. So I will give them the topical. I do think sometimes, having a patient just buy into whatever your treatment you're doing, if the topical is going to make them feel better about treating their alopecia areata, then I'm happy to give it to them. If it even just reduces a little bit of that inflammation for them, then I want to give them something that they can do to try to help with the process. I I don't hesitate to give them the topical if it's something that they want to use. I've given systemic steroids for alopecia areata. It's very few and far between. I don't use it frequently. It's very select cases. I currently have a patient that I have on systemic steroids for significant alopecia areata, and she is not a JAK candidate. So I have her on systemic steroids and she's getting good hair growth. It's very low dose, but we are using systemic steroids for a patient that JAK inhibitors are not appropriate for.
Absolutely. And I agree with you when it comes to the topicals. I think patients feel empowered when they have something to do. So whether we're actually seeing an improvement or not, I think having a topical is helpful. But also, I will sometimes compound minoxidil, assuming it's not inflamed or itchy or irritated. I'll have them use a high potency steroid with a topical minoxidil just to try to thicken up the hairs that are actually growing back. So I do think that's really helpful. You mentioned JAKs already, but of course, we love our JAKs. This is probably the best thing we've had for patients that have more severe disease. I had a patient recently, a 14-year-old girl with very severe alopecia areata. Hers was very patchy, about 10 patches throughout her entire scalp. And in that situation, realistically, injections are just not going to cut it. You're not going to do intralesional Kenalog throughout her entire scalp. And topicals were not effective. I think she had tried some topical immunotherapy, which was ineffective. And so she's on a JAK now. So I'm hoping we see really great results. So as you mentioned before, screening that candidate to make sure that they're appropriate, that they're not taking any medications that are contraindicated, that they don't have any significant cardiovascular history or cancer history. I think doing a thorough exam and a thorough history is important to choose that right JAK candidate. And obviously we're looking for significant involvement, 50% typically or greater. But I think it's important to also consider those special sites, right? If there's loss of eyebrows, which we know has a major emotional impact, loss of eyelashes, I think it's important to consider those patients as severe as well. Even if they don't have 50% hair loss, how is it impacting their quality of life? And that may sometimes get you to get these medications covered. So just something to keep in mind.
Absolutely. I couldn't agree with you more. Addressing the psychosocial component of hair loss is something we haven't really touched on enough, but really addressing how much it affects a patient on a day to day basis and really acknowledging that for the patient, that you understand how distressing this is and that you're going to fight for them to get what they need is a very, very important part of gaining the trust of a patient and building that relationship and fighting to get them the drug that they need.
Absolutely. So, any other final things about alopecia areata? I think you mentioned this already, but autoimmune disorders, obviously, we're screening for that, specifically thyroid disease or, Hashimoto's thyroiditis. I think it's important to make sure that you are doing that lab work because there is a pretty high association between those two things. But anything else before we move on to the next hair loss condition?
No, I think those are the big things. I think we've hit on the big things. Anything you think I'm missing that
Nope, that's it.
that
So
are
let's
big?
let's shift over now to telogen effluvium. We talked about this a little bit earlier and how prominent it's become in these last several years. I think there was actually two things. I've seen a couple peaks over the last few years. One was COVID. If you recall, going
Absolutely.
back a few years, when patients they would have COVID, and typically within a couple months of that, they would have severe telogen effluvium. So I was seeing a lot of that. That seems to have quieted down a bit, and now it's the GLPs that I feel like are the culprit.
I couldn't agree more. We all knew that we saw it in women from pregnancy or people after major surgeries, but COVID actually, I think, made me more comfortable really diagnosing telogen effluvium because you really did see it. I was one of those OG COVID patients who had the scarlet letter at the preschool because I got COVID early on in 2020 and nobody wanted to go near me for months afterwards. But then I got that COVID telogen effluvium, and I think it made me feel for COVID telogen effluvium patients already as a hair loss patient myself, just added on another layer of hair loss. And it it made us comfortable treating and diagnosing telogen effluvium, but it is important to not just write hair loss off as telogen effluvium just from COVID or just from GLP-1s. There are a lot of hair losses that overlap. So it is important to not just say, oh, you're on a GLP-1, your hair loss is from your GLP-1, or you just had a baby, your hair loss is from having a baby. It's important to still do that exam and acknowledge the patient for their hair loss and make sure that you're addressing, is there another underlying trigger that's causing this diagnosis, or is it just from their COVID or their GLP-1 or their pregnancy or their surgery? So I always stress that you can't just write their hair loss off as COVID or whatever the culprit is.
I agree completely. It's an easy diagnosis to reach for, especially when you're on a time crunch and you want to get out of there. But it's still important to do that thorough history, ask the right questions, do the exam. And sometimes what I find is that that telogen effluvium will now uncover this underlying AGA. So you
Right.
didn't expect to find it, but now it's there. And there's this, there's a conversation about chronic telogen effluvium, which I'm not really sure what to make of that. If it's truly chronic TE that just kind of recurs, I've had some patients who have back to back surgical procedures, death in the family, where they likely are getting a recurring TE. But I do think there's other conditions going on where patients, again, things are being unmasked by that telogen effluvium. So again, it's
Right.
worth doing a deep dive into that history. So how do you treat these patients? What are you telling them?
I, you know, Reassurance is the biggest thing. The biggest thing that I stress to my TE patients is your hair is going to come back. So this was a major stressor on your body. This happens 3 to 4 months after the major stressor happens to you, and it's going to take time for that hair to come back, but it's going to come back. But I can give you things to help the process if it's something that's going to make you feel better about it. So
Absolutely.
I use a lot of Nutrafol in these patients because I do think it's helpful. I think patients do want to use something to help treat their hair loss. And I do use minoxidil. And I talk to them about how I do think it's going to get the help to get their hair to grow. The biggest thing I stress to my telogen effluvium patients is that there is going to be a little bit of shedding when you use minoxidil. So you have to understand that if you are worried about your shedding, it can increase when I start you on minoxidil.
So, question about that. Are you prescribing oral minoxidil for those TE patients or using topical? And if they do bounce back and recover, are you discontinuing it or are they on it indefinitely?
It's a good question. I would say it's case by case basis. For telogen effluvium, I tend to recommend topical more than I recommend oral, but it
Same.
really depends on how distressing the hair loss is to the patient. I will use oral minoxidil in a telogen effluvium patient, and sometimes they get such great growth and they might have a little bit of underlying AGA that's present and they really like the density that's come back in their hair. And if they're having no side effects, I don't necessarily see a problem with keeping them on the oral minoxidil.
I agree. I definitely aim for topicals first and then I'll do orals if necessary. And one last thing with telogen effluvium that I'll mention, or a couple things. I think you touched on the exam part earlier with the dermatoscope exam, but you're not going to see that same miniaturization that you would see in AGA, right? Where you have that variability in the thickness of the hairs. You're seeing really just more kind of empty follicles or maybe no changes at all. You're just actually having that positive pull test where you're seeing excessive shedding on exam, right?
That's really where you can differentiate if there's an AGA component. You will have those patients that come in and just say, I am constantly shedding. And when you use your dermatoscope and you look, you don't see that miniaturization of the hair follicle. So when you do have that patient that says that I used to only have to wrap my ponytail holder around my ponytail once and it stayed, and now I wrap it 6 times, but there is no miniaturization. Those are the patients that I do classify as a chronic telogen effluvium patient, because they really just have that excessive shedding that's happening, but it doesn't have that AGA component.
Yeah, I think, and one final thing I'll mention about telogen effluvium, I feel like this touches on the emotional, that psychosocial component so much when it comes to patients, but kind of asking questions like what was going on a few months ago. Sometimes it is a very clear trigger, like COVID, like weight loss. Sometimes it's not. And patients, that they start kind of running it back, they're like, oh, well, I have been extremely stressed and I've been overwhelmed and I haven't been sleeping. And they'll kind of list off all the things that are going on in their lives to you. And sometimes it provokes those emotions and those tears. And so I think being empathetic, I think being patient, understanding, asking the questions, giving them that reassurance, ensuring that they're actually doing things to better their quality of life, right? Or how can we get better sleep? How can we increase your nutrition? I'll give them specific foods. I have handouts that I provide, but don't neglect the lifestyle part of this, because that's a major part of growing your hair back and preventing this from happening again. So I think it's really important just to kind of hold their hand and walk them through it sometimes, especially when you're just trying to reassure.
I couldn't agree more.
Okay. So Lisa, I could go on and on about hair loss. There's so many other conditions that we haven't had time to touch on, but I think we're going to call it right now when it comes to non-scarring hair loss. And at the next episode, we'll talk to you guys about scarring alopecia, one of my favorite things. So thanks for being here, Lisa. Yeah, appreciate it.
Thank you so much for having me.
And thanks everyone for listening.
Thanks for tuning in to Skin Sync. Don't forget to subscribe to Skin Sync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.